Now I'd like to introduce Dr. David Gass. Dr. Gass, he's the physician advisor in the Health System Workforce Branch of the Department of Health and Wellness. He's been closely involved in the development of the Physician Resource Plan for the province of Nova Scotia. He's a member of the Domestic Violence Action Plan Implementation Group for Health and Wellness. From 2008 until 2010, he was the Chief of Medical Staff at the Cumberland Health Authority in Nova Scotia. He's a professor in the Department of Family Medicine at Dalhousie University, where he's undertaken various teaching, leadership, and research roles since 1978. He's been active as a consultant in several settings, including the Psychiatry Recruiting Challenge in the community settings. David Gass.
Good morning, everyone, and thanks to the planners for the privilege of being able to speak to this group a bit about some provider perspectives on domestic violence. Some of what I'll say, as my grade 3 teacher believed, repetition was the heart of learning. So you'll hear a few things you've already heard from our previous people, but I think it just helps put the provider's role into context. So domestic violence is a health and a social issue. I would say it's under-recognized in the healthcare settings, not that it's not recognized, but under-recognized. And as Lynn pointed out, the primary origins of this problem is largely social. And so if one looks to preventing this from a primary point of view, the prevention will be a social action in areas of poverty, social unempowerment, understanding acceptable intimate partner behaviors, and racism and other isms in our society. It's also important in this context to think about how it's shaped by cultural and diversity, given the focus of today's work. And as we were reminded, women are primarily the targets, if you will, or the victims or the survivors, depending on what the outcomes are, but not exclusively. As we think of seniors who are disadvantaged or in situations where they're unempowered, clearly both men and women can suffer in that situation. But make no mistake, it's about women as survivors. And the women who are at most risk, as we've identified, are Aboriginal women, first among others, unfortunately, women of color, women with activity limitations that make them vulnerable, women with low incomes, women with no current partner are at greater risk, pregnant women, perversely, are at greater risk, and adolescent women as they begin their journey in life in the larger social world. I think it's important, though, for providers, in as much as these are the higher risk groups, to recognize that all women are at risk. And we need to be careful not just to look in the high risk areas, because this is a pervasive and a society-wide problem. The way providers would have to understand how culture and diversity shapes the approach to domestic violence is to recognize that what the experience of violence is shaped by cultural understandings of intimacy, and those are varied across cultural traditions. There are, in different cultures, variations in what's condoned as what kind of aggression may be condoned within intimate relationships. And we also need to understand that for many women, the racist experience that they and their families experience in our society will affect their abilities and willingness to report and talk about their experience when they're uncertain about the response that society will bring. Clearly, people who have to speak across language barriers and use translators face privacy challenges, and we need to be aware of how to diminish those as much as we can. People who are recent immigrants often feel at risk, even if they're not, when faced with authority figures such as myself in a healthcare system and other providers in the healthcare system, and may be unclear as to whether their immigration status is at risk if they're perceived as experiencing these kinds of problems. Disability and dependency creates fear, which can be a barrier to disclosing domestic violence. And threatened disclosure around sexual change, sexual orientation, and a variety of other characteristics people have can can be used as a threat by others to prevent disclosure. So when one thinks about the people in front of us who we encounter in the healthcare system, we need to be aware of the different ways culture and diversity shape their interactions with us. Providers in the healthcare system do have important roles because domestic violence has many health consequences, and both Lynn and Courtney identified some of those earlier. However, if we're to prevent secondary and ongoing injury and damage to individuals suffering under domestic abuse, we need to recognize the situation. We also need to recognize that all inquiries are in and of themselves interventions, and I'll elaborate a bit on that in a moment. We also know that health providers who are reluctant to ask the question sometimes are driven by the fact they're not clear about what the response is. In other words, if you're going to ask a sensitive, difficult question and uncover a problem, you want to feel you have some way to respond. So it's important that we, first of all, have responses to support people in these circumstances, and that as providers we know about them. It's also important that we recognize our own histories. Domestic violence touches many, many families, of which many of us are part in different ways. And we need to actually understand that and be able to appreciate how it affects our own ability to interact with people with this problem and fulfill the obligations we have to clients and patients that we serve. And that means we need to attend to ourselves and our own backgrounds. And finally, as people in positions of power, as health providers, we have both the opportunity and the obligation to be change agents and to ensure that we actually go beyond the individual encounter and think about how we can strengthen the community's ability to respond. So we have many opportunities to inquire. The common ones that people think about are continuing primary care. We have an ongoing relationship with a person and their family. Pregnancy care because of some increased high risk. Emergency care because often there's immediate injury as a result of violence. It can also be incidental to investigations, so lab technologists, radiation technologists, DI technologists, people who encounter people doing sensitive examinations may also come to a point where they need to identify and help someone identify that the challenge they're facing is related to violence in their life. 811, a new service, is also developing guidelines so that they can recognize from calls individuals at high risk and ask about it sensitively. And essentially all encounters around health have some opportunity to do this depending on the relationship and the circumstances of the encounter. So when we are inquiring, what's important to think about when we do this? We need to be sure we have confidential settings. Can't ask these questions in places where it's overheard by others. How we structure our environments with visual cues and printed resources matter. There's a good brochure that talks about that that's on the front, how we can use materials that recognize diversity and cultural settings, and that we're interested in willing to take action in areas of domestic violence. We need to reflect the situation we're in. Either you're simply asking because you think this is we recognize that all women are at risk and one should reasonably ask that question. May be able to tie it specifically to the injury that you're treating or the mental health condition that's present. So reflect the situation. We need to be caring, non-judgmental, and respectful. And I think primarily there, the issue given in so much of healthcare, we talk about the war on cancer or the war on disease or on some kind of a mission to eliminate things. In this environment and around this problem, that would be unhelpful. I think we need to think of more nurturing and gardening metaphors, things of the sense that we're a race that's the survival of the best nurtured as opposed to the survival of the strongest. And be clear that this is not something we're going to fix. We're going to help other people deal with it. It's important to ask about specific behaviors, not are you abused, but have you been hit? Have you been forced to have sex unwillingly? Have you been assaulted in other ways? And then around children, we need to be mindful of our responsibility to the danger to children, but we also need to inform the person we're talking to what the law says about disclosure and what our obligations will be, and that we are respectful of how much and when they're willing to talk about the risk their children may be at. The effects of asking, I just want to highlight this because it's clear that regardless, before there's an answer, you've made a significant intervention by simply asking the question. In the literature and asking people who have been survivors and victims of abuse say that the asking reduces isolation, it validates the experience that they're having, and it links that lived experience with the health symptoms so that they aren't two separate and unrelated events. It's an opportunity to provide information about resources and about your attitude towards domestic violence. It has the effect of increasing self-esteem, and it clearly signals an open door. Even if today isn't the day you're going to hear about it, it says that perhaps on another day that would be an appropriate subject to raise. Having asked the question, the response in all cases, regardless of whether violence is acknowledged or not, is a chance to provide information about resources, to make a statement that violence is unacceptable and no one deserves to be the victim or survivor of violence. And it indicates the interest in the open door, as I mentioned. If the response is positive, that yes, violence is at play in this encounter, then it's important that we actually document things accurately, that we don't document speculation, but actual events and what people reported to us, that we assess the risk of further harm and the risk of depression and suicide, because we know they're well and strongly linked to people who experience violence. We need to facilitate a safety plan. We need to refer and follow up, so we need to know about resources, and we need to assess the risk for children in the home. So given that perspective on provider interventions, where should health and wellness go next? And we're going to be talking about in our working group on provider training. We need to teach about the social complexity of this problem. We need to teach about how to make the ask, as you say. And again, in your package is an interesting and a useful, fairly short document that talks about how to ask the questions. We need to learn what the responses can be from ourselves and from our community so that we do not feel powerless in the face of the disclosure of violence. We need to address people who are in training, health professionals of all disciplines in training, and also those who are in practice and need continuing professional development. We need to be mindful of personal support for health providers, recognizing, as I mentioned before, the prevalence of violence within our families and our families' histories and its own effect on ourselves. And we need to support advocates. Again, we have the power and opportunity to affect change within health and wellness and others. We need to identify champions, make sure there's an opportunity for them to bring change within their communities, both professional and in their home communities. Cultural competence, the guidelines that were already mentioned, need to be included in the training so that there's awareness and knowledge of how culture and diversity affects the lived experience of domestic violence. But then we need to inquire and individualize with the individual person what their lived experience is, both in the context of their cultures, and there are usually multiple ones, and their own personal beliefs and life history. It's important to be open, empathetic, and engaged. Trust is important, and one can't command trust. One has to nurture and grow that. We need to signal in our work environments that it's an environment that's welcome for diversity. And we need to address the cultural safety issues, particularly of First Nations people, as Courtney outlined importantly for us this morning. That's a particularly complex and important dimension of being able to address these problems. The cultural guidelines are available on the government website. If you get on the website and search for cultural competence guidelines, and the document on how to create materials that are available for appropriate for cultural and diverse communities is again provided in the document I mentioned and is available today. It's on the website as well. So within the broad action plan, we're going to have to address facility issues of do we have confidential spaces that people can talk? Do we create environments in which support disclosure and discussion of domestic violence? We're going to look at creating print and web-based materials so that people across the province can access these and use them in their own practices and communities. We're going to talk about how we reflect culture and diversity in the actions that we take. We need to develop engage communities and develop response pathways that are known to providers within those communities. We need to make sure that the the new helplines, the 811, and if we get to the 211 line, include being able to recognize and inquire about this problem appropriately. And we need to support research and evaluation agendas so that we learn as we go forward which things seemed like a good idea at the time but don't work all that well, and other things that perhaps surprise us with their effectiveness. So this is a complex challenge for providers, both in their professional work life and in their community life. And I hope that this will give a chance to add some of the provider perspectives to our table discussions. It's really important that we integrate the community, the social, and the health and wellness perspectives. This is a complex problem. Its origins are social, its presentations are often health, and it's lived by all of us in a variety of ways. It's important that we acknowledge the courage of those who take and are able to speak of their experiences, and that we respond with being willing to act courageously on our own within our own environments. Thank you.
Thank you, Dr. Gass. In the work that we're going to do today, it's important to understand the role of the healthcare providers and the needs of the providers so we can support them in taking the opportunities to address domestic violence.